Welcome to this morning's Muscle Matters 21 online series. I'm just going to wait a few minutes for people to arrive and then we'll get started. I'm just watching the numbers go in at the moment. Right, I just need to give it another few minutes and then we can get started. Right, I think we'll now get started. So welcome to this morning's Muscle Matters 2021 online series on spinal muscular atrophy, focusing on children today. Our Muscle Matters series has become a regular feature in MDUK's calendar. We're running 2 or 3 seminars a month, focusing on a range of condition-specific topics covering both the latest research developments and also managing and living well with your condition. Each seminar provides an opportunity for you to ask questions to leading experts. As well as these virtual seminars, we're looking forward to holding 2 general information and support days for everyone affected by muscle wasting conditions in March 2023. One of them will be in London and one will be in York. These will be a great opportunity to come together with others and meet experts and the MDUK team. So do look out for further details that should be on our website in a few weeks' time. So also a reminder, our helpline remains open to anyone affected by muscle wasting conditions. And do please contact us if you have any questions or are in need of support. We can help you with information and can either support you directly or point you to where you can get support. The number and email address should be on your screens. So you can call us on 0800 652 6352 or email us at info@musculardystrophyuk.org and our team will be happy to contact you back and support you. So we're really grateful today to be joined by an expert panel covering a broad range of expertise on spinal muscular atrophy. We're also very grateful for the support of our sponsors for this morning, PTC Therapeutics, Novartis Gene Therapies and Biogen. We are actually splitting the session into 2 parts, and we will begin looking at research and then explore living with and managing your condition. Before we begin, a note on how you can ask questions or make comments throughout the session. We have some advanced questions which we will seek to cover, but we'd like to incorporate some live input. So you can do this by using the Q&A function. So please type in your question or comment and we'll feed them into the discussion. To help us manage the technical side of the event, we won't be calling on questioners to ask their questions directly. Any questions we don't manage to cover and don't answer, we'll seek to answer through the website afterwards. And a final reminder, the session is being recorded and will be available in the next few days. To start off this morning, I'm delighted to hand over to my colleague, Dr. Andrea Gubas, who will introduce our research speakers and then chair that part of this morning's session. So over to you, Andrea.
Thank you so much, Neru. I am very excited that we have a great panel of speakers with us this morning for this research session. It is my pleasure to announce Professor Laurent Servet and Dr. Lindsay Murray. Our first speaker of the day, Professor Laurent Servet, is a professor of paediatric neuromuscular disease at the MDUK Neuromuscular Center at the University of Oxford. He started his academic career at the Free University of Brussels, where he did a PhD in neuroscience. Following his clinical residencies, he continued clinical research at the Institute of Myology in Paris, where he was appointed a head of clinical trials. His current research interests include clinical trials for the treatment of spinal muscular atrophy and Duchenne muscular dystrophy, as well as the development of innovative outcome measures, including connected devices for real-life patients' evaluation. He's also the leader of the newborn screening program for SMA in Belgium through his position as invited professor of child neurology at Liège University. Today, he will speak about health economics of newborn screening. Our second speaker of the research session, Dr. Lindsay Murray, completed her PhD in neuroscience at the University of Edinburgh in 2010. Following a postdoctoral fellowship in Dr. Rashmi Kothari's laboratory at the Ottawa Hospital Research Institute, she moved back to the University of Edinburgh, where she took up the position of lecturer in anatomy. Since 2020, she has been a senior lecturer with interests in the cellular and molecular mechanisms which make motor neurons vulnerable to degeneration, with a specific interest in SMA. Dr. Murray will speak about neuromuscular junctions. Neuromuscular junctions are connections between muscles and nerves, and they break down early in SMA. Dr. Murray will speak about what aspects of this recovery are suboptimal in mouse models of SMA and what strategies we might adopt to improve it. I will now hand it over to our first speaker of this session. Laurent, over to you.
Thank you very much for this lovely introduction. Can you give me the right to share my screen or display my slide as you want? But I can certainly share my screen. Yes, well done. So indeed, I'm going to speak about the cost effectiveness of SMA newborn screening. And I must say before starting that the credit of most of data that have been generated here belong to Tamara, who is the previous PhD student of my group. So cost effectiveness of SMA newborn screening could be a good title for this talk. But we used to change it when we gave a talk with Tamara, and rather than calling it cost effectiveness of SMA newborn screening, we call it do it for money. And I'm going to explain you why. These are two kids. I've met this first one when he was 11 months old, SMA type 1C, and he could be treated by nusinersen, and it was back in 2017. So this guy is now 7 years old. He works a lot. He works a lot with the physiotherapist. He well, and this is the sister. The sister has the same deletion, the same number of copies of SMN2, but mom was pregnant when we actually start the treatment of this young gentleman, and we could initiate the treatment in the sister before she became symptomatic. So these two kids who are, and especially this little girl, who is probably one of the oldest of having been treated before the onset of symptoms, illustrates the difference between a patient who has been treated before the symptoms and a patient who has been treated after the symptoms. These two kids belong to the same family. These two kids have the same disease. These two kids have the same treatment. The difference is a couple of weeks at the treatment age. And, you know, I like to show a patient because for me, this means a lot as a physician. And of course, we have studies. And of course, we have now with this treatment, which is nusinersen, a study that has been published in 25 pre-symptomatic patients. We have 2 other studies that have been published with therapy, and all the studies show the same. And this is the magnitude of effect, right? Between patients, same families, same disease, same treatment, just a couple of weeks of difference. Then, if you just think about money, what is the cost? Forget about the treatment. Before we had treatment, before we had nusinersen, anazimnogene beparvovec, resdiplum, the cost of a patient with SMA type 2, which is a good surrogate of this young boy, had been estimated lifetime long 5 to 7 million euros, right? And little girl doing perfectly well, even if, let's imagine, she has some proximal deficit one day or another, a strong SMA type 3, forget about the treatment, was estimated to 100,000 euros, right? This is certainly not the cost of this little girl. She has no cost associated with the disease, except, of course, the treatment. But it just gives you a magnitude, an effect of an idea, a flavor of the magnitude of difference in terms of cost. So Tamara and my team started to retrospectively review the medical cost, which is the cost of the drug, of antibiotics, of consultations, therapy. That's the medical cost of our patients before the treatment, before we had any treatment. The cost, the societal cost, which is the cost of the car that needs to be adapted, the cost of the house, mom who cannot work. And she did the same in our cohort of patients when we had a treatment, but no newborn screening. And then she did the same when we had newborn screening and treatment. So look, this is a kind of visual abstract in which we can see that the cost of the treatment is huge, right? There is no question about that. The cost of the screening is very low when reported per patient, but if you screen, you have a dramatical decrease of the medical cost and the non-medical cost. So I could compute that the yearly cost of newborn screening in the UK, if you just extrapolate from Belgian cost, just an extrapolation would be 2,500,000 euros. But the total cost saved per year, if you just retrieve this medical cost and non-medical cost, is 143,250,000 euros, which is a financial return of 5,739%, which is the best investment ever, right? And it means that each minute that we do not screen in this country costs £240. So probably my talk, I'm talking for the last 10 minutes, right? So my talk has costed to you guys as taxpayers 2,400 euros, because during these 10 minutes of my talk, we were not screened for SMA. So this is a very simplistic way of seeing a thing. So you can make things a little bit more complicated. And it has been done. How can we make things a little bit more complicated? We can build a model. We can build a model and estimate what will happen lifetime long if we screen or if we do not screen, and to calculate what is the cost effectiveness of the intervention to screen. Again, I'm not talking about the treatment, because the treatment we actually treat, right? And when you build such models, then you can make slightly more complex hypotheses and say, well, if I don't screen, maybe some patients will die and I will not have to treat these patients forever. You can say, well, maybe these patients that you screen, maybe some of them will be entirely normal, maybe some of them will have some deficit, and you can modelize, right? And then if you build such a model that will be based on some assumption, you will figure out that you will, if you screen, of course, save several QALYs. What is a QALY? A QALY is a year of life with a full quality of life, right? So let's imagine that you have someone who will die tomorrow, and rather than dying tomorrow, you give this person 10 years of life with full quality of life. It's 10 QALYs, right? We used to consider in the UK that the value of a QALY is about £20,000, right? In the US, it's $50,000. So the willingness to pay in the UK is £20,000. So it means that if you bring a medical intervention, and this medical intervention helps to save you, I don't know, 10 QALYs, means that you should be ready to pay for £200,000. So it's kind of a threshold, right? Which is funny with newborn screening in SMA, is that when you save a QALY, and that's this model built in the Netherlands, when you save a QALY, you don't have to pay for this QALY. You receive money, which is quite weird. I mean, in health economic, it's not that frequent. And if you do something that improves the life and the quality of life of people, it doesn't cost, it makes money. It's quite rare. And you know, when we discuss with our health economic partners, they say, wow, that's not that frequent. So this was a model built in the Netherlands. And there is a similar model built in the in Hong Kong, in Australia, I'm sorry. And look, again, we are in the negative, and in the negative area when you consider treating patients with gene therapy at birth rather than waiting. And the QALY that we save by treating our patients after the symptoms, whatever is the treatment, we have to pay a lot. That's what we can see here, up to $4,500,000 for 6 QALYs. But even if we consider the very high cost of the treatment, if we screen at birth, we are still in an acceptable range of QALYs per dollar spent in the context of a treatment, which means that if we want to get an acceptable health economic impact with these super expensive drugs for SMA, the only way to do is to screen and to treat. And if we just consider the activity of screening, because we made the decision to treat and to spend money to treat, then we make money by screening, and we make money for every single QALY that we save. These models have been built on the data from the studies. So what we've done in Southern Belgium is that we have constructed a similar model, but using data of real life of our newborn screening program that is now nearly 5 years old, and collecting different information from different sources for our patients, including HUI. And to make a long story short, again, we developed a similar Markov model, and considering that a threshold of 1 QALY of $50,000, so that's our classical Markov model. What we could show actually is that if you consider the different aspect of the disease, which is the societal perspective and the impact of caregivers, or even not the impact of caregivers, but the loss of patients' productivity, again, this is a negative cost per QALY, which means that you make money when you actually save a QALY in this patient. So the conclusion is newborn screening for SMA. If you don't care of your patients doing better, if you don't care of having patients running in the street, cycling in the street, rather than being wheelchair bound, if you don't care of kids not spending their lifetime in the hospital for infection, if you don't care of patients' health, at least screen for money, because then it saves money for the society, for each QALY that we gain. Just to finish this talk by acknowledging the work of my team in Belgium, who has been instrumental in this data collection. Tamara, who has been leading this effort, and my partner in crimes for the newborn screening, and Professor Michael Lixman, who has been instrumental also in the interpretation of this data. Thank you very much for your attention.
Thank you, Laurent, for this great talk. I will now just hand over to Lindsay, and then after her talk, we can have a nice Q&A all together. Lindsay, over to you.
Okay, I hope that you can hear me and I hope that you can see my slides. Can't see you at the moment, but hopefully
we can see your slides and we can hear you.
Fabulous, that's good news. Okay, thank you for the introduction and thank you for the invitation to speak today. It's really nice to be here. And nice to share some of our research, which is partly funded by Muscular Dystrophy UK and partly from other sources as well. So just to...
Sorry, Lindsay, we can see the presenter view and not the full screen. Sorry.
Hold on a minute. Is that better?
No, it's the same. Oh, now it's better, yeah.
It's better now? I'm okay?
Yeah.
Okay, great, good. All right, we'll keep going. So yeah, me and my team are rather obsessed with these little things called neuromuscular junctions. These are the connections which motor neurons make with muscle. You can see the illustration there on the left-hand side of the screen, where the motor neuron which resides in the spinal cord extends its axon out through and carried in peripheral nerves and reaches a muscle and makes a connection with a muscle fiber. And you can see a zoomed in picture of one neuromuscular junction there in the middle. You can see the green axon, which is coming in and forming what we call a presynaptic terminal. It's basically the neuron side of the handshake, which it makes with the muscle, which is shown in red. The red there is showing receptors on a muscle fiber. So the green bit's the neuron, the red bit's the muscle. And as you can see here, they form this really rather intricate connection with each other, a very, very specialized structure. And it's really critical for communication of the nerve impulse to the muscle. So this is how the nerve communicates with the muscle. This is how it tells the muscle to contract. And on the far right there, you can see that we can see many neuromuscular junctions throughout a muscle. You can see one axon coming in and spreading out and making connections with many muscles in a given muscle. So as I said, me and my team are slightly obsessed with these. We over the years have studied them in many different contexts. And one of the great things about neuromuscular junctions is that they are you can tell a lot by just looking at them. Their structure changes depending on how well they're working. And just as if you were to meet a friend in the street and you could tell very quickly whether they were okay or not, a trained eye can look at a neuromuscular junction and tell quite quickly whether it is all right or not based upon how it looks. And we've been doing that for many years in SMA. And really the take-home messages are the neuromuscular junctions okay in SMA? No, they're not. And I think that's something that we're all be quite familiar with over the years. And this is a picture, this is taken from a mouse model, a mouse which is designed to mimic SMA. And there's a number of things that you can see there quite quickly. First of all, you can see that there's clusters of red bits with no green bits, basically. So there's receptors on the muscle fiber. There's bits of the muscle fiber there that no longer have the neuron. So the neuron has withdrawn, it's pulled back, it's gone, which is a sign of the degeneration which is happening. You can also see that some of the other terminals are very swollen. They're very lumpy compared to how you would see in a nice, healthy individual. You can also see they lack a degree of complexity. They're much simpler connections. And that's very much indicative of their poorer function. The complex anatomy is really related to their physiology and their function. And when it's not working properly, the complexity doesn't develop. So as we've known for a long time that neuromuscular junctions in SMA don't look normal. And the changes at neuromuscular junctions seem to happen very, very early in disease. In our mouse models, changes at neuromuscular junctions seem to correlate with the onset of symptoms, with some changes happening before symptoms start. So it's a very, very early change. And so in more recent years, of course, with the advent of the new treatments, we've been really interested to look at what happens to these connections when treatment is administered, what kind of regeneration can be obtained, and is the recovery of these connections complete, or is there room for improvement? And so just to try and summarize a kind of a sort of body of work. So I apologize for the change in colors here. I'm just trying to be a bit more friendly to the colorblind. the receptors are shown there in magenta and that purple color, and the neurons are still in green. But hopefully you can see that when treatment is given, the neuromuscular junctions look an awful lot better. We've quantified that there over on the right on that graph, and what you can see is in our control mouse, as we would expect, everything is what's called fully occupied. So every end plate has a neuron, every muscle fiber has a neuron, so that's what is the ideal. In SMA, you can see huge numbers of receptors in the muscle fiber that do not have a neuron, where they are what we call denervated. And after treatment, actually, the vast majority of them once again appear fully innervated. And I think that's really encouraging. And actually, in this system here, this isn't, treatment is perhaps slightly misleading in this. And this specific data actually comes from a mouse model we use, where we can actually just genetically switch the damaged gene back on. But the same result is true when you do it with a viral vector or whether you do it with an antisense oligonucleotide, the same thing happens. And it really is a testament to how incredibly regenerative the peripheral nervous system is. When you get injuries in the central nervous system, there's lots of barriers to recovery. But in the peripheral nervous system, huge amounts of regeneration is entirely possible if the conditions are right. So of course, all the muscle fibers which had receptors which were left seem to be re-innervated. But we were quite keen to look at that in a bit more detail to see how whether there was any defects which still persisted despite the fact everything was still innervated. And to do that, we did a number of things, but just to summarize, I guess, one of the things we did was actually to physically count the number of neurons which is entering each muscle. So these are called axons. They're basically the wires that are re-entering the muscle. And we counted the number of axons that we would expect in a normal healthy mouse, and we counted the number of axons we saw in an SMA mouse which had been treated. And what you'll notice there for the quantification, which is over on the right, is that there's actually a really dramatic loss of the number of axons which were there even after treatment. We also counted the number of connections which remained in the muscle, so the total number of connections within a given muscle. And again, we saw a massive drop in some of the muscles that we looked at. So I think this is for us really important. First of all, it shows just because the connections which are there, and that's great, but there's not as many of them, and there's not as many axons, and there's not as many connections with the muscle. So there are deficits there. There is room for improvement. And I think this is an area which would be really interesting to look at in the future. We clearly, as Laurent just very nicely illustrated, there is this clear window. There is this very rapid decline very early. And it's clear that interventions at this point that can stabilize the connections and can protect them in this very critical time window, very, very early in disease, could actually have really, really long-ranging impact. And there's lots of things that we can look at to do that. There's lots of molecules which are involved in regeneration. There's lots of molecules which are involved in stabilizing connections. And it may be that targeting these with new drugs, which can just stabilize these connections and enhance regeneration in this critical time window, can have really long-ranging benefits to the treated patient. So this is certainly something that we're looking at the moment. We've got some ideas of some pathways which we think could be really helpful in doing this. And we're looking at some test drugs to see if we can stabilize these connections in this critical window. The other consequence of this is what's called the motor unit size. So every one neuron which exists in the spinal cord will supply many, many muscle fibers. Each muscle fiber will only receive one neuron, but that same neuron can innervate or supply many, many muscle fibers. And you can get an estimation of how big a motor neuron is, i.e. how many muscle fibers it contacts, by dividing the number of axons which comes into a muscle by the number of connections that it makes. We call this the average motor unit size, the average size of the motor unit, or the average number of connections that a motor neuron makes. And what you can see is, because of the reduction in the number of axons coming into a muscle, we actually get a massive increase in the size of the motor unit. So each neuron is actually making way more connections than it ordinarily would. You can see that in the picture there. It's the same picture I showed you earlier, actually, of one axon coming in and making many, many connections with the muscle. You can see on the picture in the bottom right, this is happening by a process of sprouting, where basically new growth to extend from existing terminals to go and supply the connections which had been lost. Again, this is a wonderful demonstration of the adaptations which happen in the peripheral nervous system, how it can regrow and how it can compensate for the defects which have occurred. And it's a process which occurs in all of us. During aging, we get sprouting and we get regeneration. The issue we have here, of course, is that this is something which is happening in patients which are very, very young. And a big question is what's going to happen in the long term to these connections? What's going to happen to these neurons, which are very large, abnormally large? What's going to happen to them over time? And we don't know the answer to this. It's absolutely clear that we do not know what will happen, and maybe it will be fine, but there is some precedent from other conditions to arouse our suspicions and consider that it is possibly not going to be okay. So we need to keep this in mind. This is something that we need to keep monitoring and keep an eye on. And we're currently in the lab looking at ways to support these very large motor units, to if we can intervene with drugs which can help support them through the lifespan of the patient, help ease any stress which is put upon them. So this is certainly another avenue which we are currently pursuing. So just to summarize what I have talked about today in these pictures, basically we have these neurons which make connections with the muscle, and in SMA these neurons are lost, which leaves these connections broken. The neurons which remain are incredibly plastic. They are able to grow new branches and remake connections which have been lost. But some connections which have been lost actually fade away and are lost completely. And also we end up with reduced number of neurons which are supplying muscles. And the consequence of this is fewer connections and enlarged territories for those neurons which are left. And our current interest is to look to see if we can both encourage the regeneration and support the connections and protect them in the short term, and over the long term find ways to support these enlarged neurons which have performed their compensatory function. So with that, thank you very much for your attention, and I'll hand back to the moderator.
Thank you so much, Lindsay. So thank you both for really great talks. I'm very happy to open the Q&A session now. So please, if there are any questions from the audience, do put them forward in the Q&A box down at the bottom. We do have a couple of questions to start with. So one of the questions is, with 3 treatments available now for SMA, what are your thoughts? Is there a risk that the research into SMA could slow down now? Whoever would like to take this question, or the two of you.
Well, I can maybe try. So first, the patients who have been treated after the symptoms, none of them is cured, certainly not, and only a teeny percentage of them are ambulant, which means that the unmet need in the population today is huge. In the prevalent population is huge. The UK has not yet decided to screen, which means that we are continuing to produce a population of about 60 or 70 patients every year who will remain with a significant unmet need in terms of treatment, because all these treatments, yes, they are efficient, but with a limited efficacy that is related to the fact that there is a certain pool of motor neurons that's there and that's it. What are the, let's imagine that that's the, let's say the big piece of research is how can we help better patients who have been diagnosed after the symptoms and who have been treated after the symptoms, and only a small percentage of them are ambulant. First question. Second question is, when we conduct newborn screening, we also identify patients with very severe and very early onset of disease. These patients previously they died, treatment or no treatment. Now they survive, and they survive in quite good condition. For instance, I do not have any non-ambulant patients identified by newborn screening. They all walk, but the patients who are clearly symptomatic when I see them, nevertheless, they have not a normal ambulation, right? So there is still an unmet need in this population. And then the next level is obviously how can we do better? How can we treat even earlier? Is there any treatment that could even be more efficient than those we have? And could we start treating in utero for patients who have been identified before delivery? So that's, I think, for me, the three line of questioning for SMA. So I'm pretty confident that until my retirement, we'll still have open questions for research. I'm less sure for Lindsay, but at least for me, I'm pretty confident I will have things on my plate until my retirement.
Yeah, I would very much echo your sentiments on that, Laurent. I think I think the SMA field has never been more exciting than it is now. As a researcher, we're now dealing with a brand new disorder. We're dealing with a chronic disability rather than an acute degenerative event. And I think that's really is very interesting. And for us, actually, there's an awful lot of actually going backwards in many ways. You know, there was an awful lot of ideas for interventions which were developed and discarded because SMA was so severe and so dramatic and so you know, it was so difficult to help that these interventions were never likely to make much of an impact. But now I think it's really worth returning to these and saying, actually, as combinational therapeutics, they might have enormous potential. So I think in that regard, and as I've outlined, I think as speaking, I think there's a huge gap where we can be intervening to provide better outcomes for these people who are not they're not cured. There's still clear problems there, and if the starting point was where patients are now, people would be very willing to accept that was not good enough. It's because we've gone from such a terrible situation to a better one that people think that that's then okay. That's not okay. There's still a huge amount to be done to improve outcomes for patients. I think the enormous challenge of SMA is the fact that often our funding is coming from in competition with other disorders that do not have a treatment. And that's a massive challenge, because when you have a limited pot of money and you have other disorders, they often are out competing our need, which is difficult. But I think what we need to do as researchers is actually start making the case that what we're learning in SMA is of massive benefit to all these other disorders, because we have a unique scenario where we're actually be able to detect smaller, more incremental improvements that would be impossible to detect in other disorders which are more severe. So I think that we need to, as researchers, be good at building partnerships with other disorders and keep advocating for the need for research. And that's going to be our challenge. There's certainly a lot to do. There's a lot of need. We've just got to keep up the momentum and keep drawing new people into the field and keep attracting new funding sources to keep doing it.
Thank you both. A really great answer. We have a couple of questions from the audience. So the first question is, are there any advantages or disadvantages of switching from nusinersen to risdiplam, and does it depend on age, condition? So they have a son that is 14 years old with SMA type 3 as an example. Would you be able to say anything?
I'll leave that one to Laurent.
Thank you so much. I'll say that for any treatment, and whatever is the switch, from A to B, B to C, C to B, B to A to B plus C, B plus A to C, don't switch for efficacy. I'm not aware of any evidence that switching from any way to another could result in an increased efficacy. Then people will tell you, well, there is this real-world evidence and this Facebook pages, and so I agree, but I'm talking about strong evidence. I'm not talking about a case report. So efficacy, it should not be the reason why you switch. If we switch, it's for safety, or if we switch, it's for sometimes the convenience and how to deliver the treatment. So for instance, a patient with a scoliosis that progress, because unfortunately, a patient with a scoliosis, whatever is the treatment, will continue to progress the scoliosis. I'm not aware of any treatment stopping a scoliosis. So short answer is, do not have any expectations in terms of efficacy when you switch. If you want to switch for convenience or switch for safety. That's the two good reasons to switch.
Thank you. I guess the second question is, are there any potential side effects related to sperm production with risdiplam and whilst taking the medicine? And is this also the case with nusinersen? Is there any concerns? Are there any concerns about this? Maybe Laurent, would you, or
Yes.
Lindsay, if you.
So Lindsay, how are the neuromuscular junction in the spermatozoids? No, just joking. There is actually no. There was an initial fear from the fact that indeed the spermatogenesis could be altered in patients on risdiplam, and then there was several preclinical and clinical investigation done, and to make a long story short, this is entirely reversible, which means that if you are a male and you take risdiplam, you just have to stop risdiplam 2 months before considering having a child, and it's perfectly okay. So it's just a matter of time. For ladies, it's 1 month, which is quite a current features that we do not advise to continue a drug when a lady is pregnant. So 1 month for a lady and 2 months for me. So it's entirely reversible. For nusinersen, we do not have a same concern for spermatogenesis. We did not add a same concern. Nevertheless, it's still not advised to have a pregnancy if you are on nusinersen. This being said, the half-time of nusinersen is much longer, right? So if you say, well, I'm going to stop nusinersen 2 weeks before being pregnant and getting my last injection 2 weeks before being pregnant, I mean, you are technically on nusinersen for the entire pregnancy. You need to consider the half-time life of the drug, right? But again, to make a long story short, no problem. You just have to stop risdiplam 2 months before considering being a dad.
Thank you. So another question is, so there have been talks about the combined trials for SMA, and so 2 treatments are used, and I guess so the question is, how can the children be put forward towards these trials?
So unfortunately, here in the UK, we are facing an incredibly difficult situation because, as you probably know, there is a anti-myostatin drug that is 3 anti-myostatin drugs that are in trials. We in Oxford are coordinating investigators for the 3 drugs, but we have been told by NICE that unfortunately patients cannot be in the managed access program and be part of a clinical trials, which is, well, I prefer not to try to qualify this, but it means that to include patients who are in the managed access program, which is virtually nearly all patients except those who are in Sunfish trial, for instance, is going to be incredibly difficult in the UK. So we are currently trying our best to make a solution, but so far it's a no-go, which is, in my opinion, terrible from a national perspective, because we shoot a bullet in our own foot by not being able to deliver on clinical trials in a country, which is extremely bad for the reputation of this country. This is crazy for patients, because we have plenty of patients contacting us to join these trials. So this is quite a very sad news for the UK SMA community.
Thank you. Lindsay, do you have anything to add?
I'm certainly going to leave the clinical questions to Laurent. I think he's much better informed to answer those.
Okay, thank you. Okay, so the next question is about the patient-reported outcome measures. how useful is that data, and what is being used for, and can parents add data for their children into the PROMS database? Who would like to?
So I think that outcome measures, we are facing an issue in SMA, which is that when you look at the data from Sunfish, for instance, in patients 2 to 24 years old, and you compare patients between placebo and risdiplam, then you improve by 1.4 points on the MFM after 1 year of treatment and using 180 patients. When you compare placebo and to untreated and treated patients. So the next level now is to compare patients who are treated and who on top of that receive an additional medication, which means that you do not expect to have a similar effect, right? You expect to have an effect that is probably a little bit less than if you compare just with treatment or off treatment. So which means that if we are only able to capture a change with 180 patients, when you compare on and off treatment, how many patients do you need when you would have to compare patients on treatment plus an additional one? And I mean, this is not trivial at all. PROMs are useful, but they will not fix the problem. They will not solve the issues because of the sensitivity to change. In PROMs, PROMs provide us with incredibly important information about what the patients feel about the disease and how they feel improved or not. But the problem is that there is a part of subjectivity, and myself, if you ask me how I'm doing, there are days I don't feel good for any other reason that is not related to my health. So we need to understand that PROMs brings a lot of value from a payer perspective, for instance, or as a secondary or tertiary outcome in a trial to support a primary, but it's not going to help in the problems of getting a better sensitive outcome measures in these patients that allow to conduct trials and to identify a significant difference in a smaller group of patients.
Thank you. I have a question for Lindsay. So when you were showing your really lovely pictures of neuromuscular junctions, when you use the treatment, is there a particular one that you use? Did you try like all the available ones, so if I remember correctly, this was done in mice, and have you done any experiments on like patient-derived cells?
Thank you for the question. So yeah, we use different systems in the lab. Some of them are not particularly translational in terms of we have a mouse model where you can basically turn the gene on, and we've used that a bit. But we've also done more relevant approaches. We've used ASOs, so similar to Spinal or nusinersen. We've used the AAV9 as well, and we get very similar results regardless of how we do it. Yeah, we've used different approaches to do that. Trying to remember the next part of your question was what human trials we see that. Yeah, so we've not used human derived cells. So right now there's a huge amount of work which goes into trying to create neuromuscular junctions in a dish, so trying to get human cells to connect with muscle fibers in a dish, and this work is certainly progressing, and it's coming to the point that it may become useful. I'm sure will become useful. At this point, it's not a system we have in our lab, and I still believe that looking at the recovery in terms of the, all the different cells which have to interact to make that happen, you have to first of all get a degenerative event, and then you have to be able to intervene and get a regenerative event. the cellular models are not at the stage yet where you could model that. So right now they're picking up some smaller, maybe some degenerative stuff, maybe some electrophysiological disturbances is what's been picked up so far, but we don't yet have a system where we've been able to intervene and rescue defects, so that's coming in the future. I think it's not there yet. There are parallel studies going on. People are studying the recovery using electrophysiological approaches in patients, and I would say so far the data is very similar to what we're seeing, in the fact that they're seeing a very impressive recovery, but the recovery is not complete. It's one of the things which I think is so interesting and is really mystifying us is how this recovery is actually happening. You know, we talk to patients and they talk about getting functional gains. People who've lived with this disease for decades often are getting functional gains, and I think many people are quite bemused about how that's actually happening. How are we getting those gains? Are there these dormant motor neurons which are sticking around for longer than we ever thought possible that are regenerating? Is this coming from sprouting and regenerating from those neurons which are still present? We don't know, and I think that the parallel between the mouse studies and the patient studies are going to be really important in working that out. It's going to be such an important thing to determine, so that we know how to intervene to improve. And as I said, I think for a long time I was always of the opinion that once the connection was gone, the motor neuron was on its way out, and there was very little you could do about that. I think from some of the data we've seen more recently, I think that the motor neurons may hang around for slightly longer than I thought they did. And I think that the honest answer is we really don't know how long they stick around for. And I think that's going to be so interesting to actually try and figure that out.
Thank you so much. We have another question from the audience about, I guess just a follow-up question about the risdiplam and reproduction. So this individual wonders, is there any side effects concerning development of children in relation to puberty and maturation? Laurent, would you?
Short answer is no. There is no side effect concerns. Easy.
Good. I guess that's probably it for the research session. Any other questions will be.
Sorry, I see in the chat an interesting question of Agnieszka about how much physiotherapy, occupational therapy is required.
So we were thinking we can discuss this in the Living Well session, because we could involve more people in this discussion, but so that's what I just wanted to say, that the other questions will be answered in the next part of this chat, this seminar. And thank you both, Lindsay and Laurent, for great presentations. And I would like to hand it over to Rob now, who's back with us for the Living Well session. Rob, over to you.
Huge thanks, Andrea, and thank you so much to Professor Servais and Dr. Murray, and also to Neeru for covering for me at the beginning as I snuck off to watch a school play. Child number 5 is a very big role in a school play. I'm Rob Burley. I'm Director of Care, Communication and Support at MDUK, and it's my pleasure to join us halfway through and to guide us to the next part of the seminar, focusing on living with SMA. I'm pleased to welcome some more panelists to join us, and I think Laurent is staying with us as well, which is fantastic. I'll introduce all the speakers now with a short bio, and then I'll invite them each in turn to say a few words about their area of expertise on this topic and their experience of SMA and the support they provide. And then we'll move into questions and answers. So we've had some advanced questions specific to this section of the seminar. And as Andrea pointed out, there's a couple of questions that are kind of already more relevant for this panel. So do remember to keep using the Q&A function as we go along. So I'm delighted to welcome Dr. Elizabeth Raig, who completed medical training at Guy's Hospital in 1990 having first completed a degree in microbiology at Leeds University. She followed her two main areas of interest, paediatrics and neurology, from an early stage, and completed training in a paediatric neurologist at Guy's Hospital in 2002. As a registrar, she developed a particular interest in neuromuscular disorders and was appointed to a substantive post as a consultant specializing in paediatric neuromuscular disorders in 2003. She's co-led the clinical neuromuscular service at Evelina London Children's Hospital with colleagues and facilitated the delivery of new therapies, including Spinraza for SMA, and most recently has established an infusion service for the delivery of Zolgensma gene therapy. Jenny Sheehan is a clinical specialist paediatric physiotherapist, also at Evelina London Children's Hospital. She has over 30 years of experience in working in neuromuscular disorders, mostly in paediatrics. Jenny runs physiotherapy-only neuromuscular clinics, in addition to multidisciplinary team clinics with 3 consultants. The service also runs outreach clinics. Jenny is on the steering committee for the SMA Reach Network and a member of the NHS England expert panel for SMA, and is involved this year in a NICE consultation on gene therapy. And Evelina is one of the 4 infusion centres for Zolgensma. So Jenny is also a member of the national multidisciplinary team. Eleanor Conway is a specialist speech and language therapist and has worked at Great Ormond Street Hospital for over 10 years and with neuromuscular conditions for the last 4. The majority of the work at Great Ormond Street Hospital has focused on supporting young people with their eating and drinking skills, but she also has experience in supporting communication difficulties. Dr. Philip Davies is a consultant in paediatric respiratory medicine in the Royal Hospital for Children in Glasgow. He trained in Cambridge, Manchester and Cardiff before moving to Glasgow in 2008 as a consultant. His clinical interests include children on long-term ventilation, sleep medicine and children with neuromuscular disorders. He runs a regular multidisciplinary neurorespiratory clinic that manages children with neuromuscular disorders from throughout the west of Scotland and has worked closely with the Scottish Muscle Network for many years. And finally, Portia Thorman is advocacy lead at Spinal Muscular Atrophy UK, SMA UK. We at MDUK work very closely with SMA UK and really value our partnership and relationship with Portia and colleagues. So it's great to have you with us, Portia. After obtaining a degree in psychology, Portia trained to become a primary school teacher, so probably had to run a few school plays as well, and worked in the classroom for over 10 years. In November 2016, Portia's son Ezra was diagnosed with SMA type 1 at 4 months old and received his first dose of Spinraza at 6 months old, who was one of the first to receive the treatment through the early access program. Given the severity of his condition, Ezra is reliant on 24-hour care, but despite this, he lives a very full and active life in his power chair and has just started year 1 at mainstream school. With Ezra starting school, Portia found that she had more time on her hands and was very privileged to join the team at SMA UK as advocacy lead in January this year. And she now also sits on the SMA Reach and UK SMA Newborn Screening Alliance steering committees. So I think a big theme we're going to explore is the package of people who support people living with SMA, and I think that speaks to the size of our panel. So it's fantastic to have you with us. So Dr. Ray, could I come to you first, and could you talk us through sort of the wider holistic care and support that's provided to babies and children with SMA, and the different elements of the service that you'll run and coordinate as the consultant? It'd be great to just hear a bit about the team at Evelina, and Lauren, you may want to come in as well about what happens at Oxford. But Dr. Ray, can I start with you?
Yes, of course. Thanks very much, Rob. I'll do my best to answer that. So I suppose the first thing to say is Laurent has very clearly presented in his talk that currently in this country we don't have newborn screening. So children with SMA are diagnosed when they develop symptoms, and that's unchanged really over the last 20 years. But what has changed are the treatments that we have available for the condition. Things will change further when newborn screening is approved in this country. And I'm putting that forward in what I think is a positive way, because I find it very difficult to think that we will continue to work in a country where we don't have newborn screening, given the very clear benefits, both on the health basis, but as Laurent has also put forward, economic basis. So I think we all wait for that moment. Currently, the situation is that that children with SMA and babies with SMA are diagnosed when they develop symptoms. And those symptoms relate to the muscle weakness that occurs in SMA. And there are spectrums of severity within SMA, from the more severely affected with type 1 SMA, who have problems in very early infancy, through to those with the less severe forms, where they will start to develop problems in childhood, with difficulty with type 3 SMA, with difficulty with their walking, for example. So they will achieve walking, but will then go on to have difficulties. When we see a baby or child with SMA, it's really important that we think about the holistic care, in fact, and that we think about the overall management. So that is thinking about the impact on their swallowing, their feeding, their breathing, as well as their general movement. And this can mean many different assessments that are necessary from various therapists, and a number of investigations that might be necessary to understand those aspects better and to make sure that the right support is put in place. I said at the beginning that the thing that has changed over the 20 years is the availability of treatments. And we have now, of course, 3 treatments that are available to use. Zolgensma is the only treatment that is what you might call routinely commissioned by the NHS, so that that's available for prescription to be delivered to an infant with type 1 SMA in this country. Spinraza and risdiplam are available through what are called managed access agreements. So still available as treatments, but it's a slightly different process. We've already heard earlier in this webinar the importance of starting treatment early, and I think Laurent also put that point across very well, that it's not so much which treatment in terms of effectiveness, it's how quickly can you start that treatment. So for all 3 treatments, the best effects are seen if started early. And so there is some urgency once a child is diagnosed with having SMA, or I'll take that back a step actually. When SMA is suspected, we have an urgency to make a diagnosis. So we see a child without a diagnosis of SMA, but it's suspected, and we want an urgent result from our genetics laboratory. We do a blood test, send it to the genetics laboratory, and we want urgent confirmation of that diagnosis. And once we have that, then we really need to think about which would be the ideal treatment for the child. And I think, as Laurent said, it's not so much about the efficacy, it's actually about the safety of the treatments. And there are some stipulations that have been put in place, particularly with nusinersen and risdiplam, around the managed access agreements, about which children might be eligible for particular treatments. So we have to consider those aspects. We also have to consider what the side effect profiles of the 3 different treatments are, and which would be safest for an individual. So for each individual baby or child with SMA, a doctor such as myself will be spending their time with the family, thinking on an individual basis, what are the risks of each of these treatments for that child, and which would be the best treatment to start. And the priority being to start a treatment as quickly as possible. And within all of that, not forgetting what I started off with saying, that we have to also think about how we manage any problems that there are with things like feeding safety and breathing, and then the involvement of physiotherapy colleagues thinking about the therapy aspects that might be beneficial for a child. I work in a hospital, and the families come to see me in the hospital, and it's a very artificial situation then, spending time with them, and you get to know people over time, but most of their life is not in a hospital. There are some infants who spend a considerable amount of time in hospital, and for some of them the start in life might be mainly in hospital, but ultimately we're looking to people being at home, and most of their time is hopefully out in the community. And so I think that holistic care also has to think about, how do people get the best out of life really at home, and then as they get older at school, and getting the right educational opportunities. and of course growing up and then working in the world. So I don't know if that helps to answer some of the aspects, Rob, if there's anything in particular you wanted me to talk about within that.
No, I think that's a fantastic intro, Elizabeth. Thank you. I think kind of you've teed up nicely the kind of specialists to come in behind you about their areas. Also, I'm noting the reference to both screening and managed access agreements. We might come back to those a bit later if we've got time. But Jenny, if I could come to you next. Elizabeth mentioned some physiotherapy, and it came up in the research question. So we'll come back to the specific question about physiotherapy and research in a bit. But it'd be great if you could give us an overview of the kind of physiotherapy support that you and colleagues provide to children and babies, and also why it's so important in the care of SMA.
Okay, thank you. So there are two real roles really for the physiotherapists in neuromuscular centres. One part is completing the standardised assessments, which is really important to submit that data to SMA Reach. So we're looking at a number of assessments: the high knee, the chopping tend, the revised Hammersmith, the EK2, the upper limb RULM. And they are all important to monitor progress, and they're important to assess if a child is meeting stopping criteria for any of the treatments that we're now offering. So that's really important and quite time consuming. But the other part, which is probably the more important part in my opinion, is how we can help those children and those families. So we're also looking at muscle strength, joint range of movement, spinal posture. And with that in mind, we're looking at seating and their functional ability, not just what their scores are, but how that impacts on their daily life, which is more important. So we're advising on physiotherapy, but physiotherapy can be, hands-on physiotherapy, but no child is going to get as much physiotherapy as they want. So it's important that the carers or the assistants at school are trained with what to do. So that might be passive stretching, or more importantly, assisted stretching, where the child is joining in with that activity. It might be games or play that involves using strength and working on functional ability. All sorts of things that we have that we can advise on. It's also really important that we look at seating. We tend to, on the whole, see the children more often than occupational therapists do, and seating is something that falls between both of us. So we address that. We're looking at sporting activities, wheelchair activities, and anything that we can engage the children in with that point of view. So we then liaise with the community physiotherapists and advise. And our community colleagues are really busy. They have huge caseloads, and they probably only have one child with SMA. So they do need the advice from us. The advice with children with SMA is very different in lots of ways from physiotherapy for children with cerebral palsy, which would be most of the caseload for community physios. So they need us to advise on how to do things with this cohort of patients. So I think that's probably the more important side, is guiding the families. So we do the assessments, but what do those mean and how can they help? The other aspect of that, I think, that has come in a lot is dealing with family expectations. And that can be quite a tricky aspect, that everybody, the treatments are good and they are having an effect, but sometimes expectations are a little bit higher than is manageable, than is achievable, and we have to help with that.
Thank you, Jenny. That's a really interesting point. I think we'll come back to that as well, and bring in Laurent and Elizabeth on that thing about the sort of treatment expectation as well. Eleanor, could I come to you next for a sort of similar overview of the kind of support that a specialist speech and language therapist might provide to children and families with SMA? And I sort of noted that you support with swallowing as well as communication, but primarily sort of swallowing. That would be interesting to hear a bit more about that.
Yeah, thank you. So I think in neuromuscular conditions, often there's quite a lot of physiotherapy support and quite a lot of understanding about what's happening with some of the bigger muscles that I would call sort of arms and legs muscles. And sometimes the speech therapy portion is always quite a small caseload. And what's occurred with SMA is this growing number of children who have a really wide spread of ability in terms of how they can work the muscles of their throat. And some children are eating beautifully, speaking beautifully, and we have other children who are really having some major difficulties just even swallowing saliva, or getting a good enough voice out that they can be understood in, say, a classroom. And we've really felt slightly, I certainly in this centre have felt slightly on the back foot in terms of catching up with the knowledge of what the treatments are doing and how they're affecting children. So I think sometimes prognosis for things like eating and drinking and talking has been a much harder thing to define for families, and the expectations are more difficult to quantify, because the effect of the treatments on the throat muscles seems to have been different to, say, the arms and legs muscles. So we very much work much more with looking at the patient on an individual basis and where they're up to and what the possibility or trajectory might be for their eating and drinking and their swallow, and also for their ability to communicate. And I think for us, we're still very much learning the effects of the treatments and what that means, but also we have a slightly different role in that sometimes eating and drinking has a safety aspect on your respiratory function. So if you're allowed to eat and drink, but it's all going down the wrong way, that might affect your lungs, which ultimately will affect your bigger health outcomes. And I think that's been quite challenging for us, is balancing these young people who really want to eat and drink and maybe can't do it very safely, and the effect on their lungs, and the goal being to keep them well, for the next treatment, to get the next treatment, to be able to have even more sort of benefit in terms of their physical abilities. And I think that has been a very tricky balancing act with lots and lots of our young people, and continues to be quite difficult. And I do think eating and drinking and talking, particularly for young children, it can be quite emotive. This is very much a parental role to feed your children, and it's something that we see quite a lot of difficulty with, certainly in very early stages of childhood. And I think that's been really challenging for lots of our populations across the sort of spread of SMA. So in Great Ormond Street, we offer specialist assessment to really quantify what the muscles are doing and help families make decisions about eating and drinking. We also have a team that offer very good communication assessments to look at children's cognitive function, but also potentially their ability to communicate effectively. But we also definitely rely very heavily on our community counterparts to kind of underpin and oversee a lot of their treatment. And we know that access to that has been really challenging in lots and lots of centres.
Thank you, Eleanor. That's fascinating. I think there's a strong theme that I'll come back to at the end of everyone's remarks around expectation management and the impact of the treatments sort of coming through on services. That'd be really good to sort of touch on that. If I could come next to Dr. Davies, would you mind just talking us through the role of a respiratory specialist and why that's such an important aspect of care and treatment for children with SMA?
Yes, thank you. I mean, everyone thinks about muscles in terms of arms and legs and things you can do, but of course, breathing is essentially a muscle-driven process. And of course, breathing with the traditional SMA ones that have, without the treatment, of course, has been the cause of respiratory failure and death. And so, obviously, with these new therapies, the ability for what the impact that's had from a respiratory point of view has been enormous, but also I think it's important to recognize through what we're seeing clinically on the ground is that this is not actually a problem fully solved, and so it still requires very much active management. And there's lots of different aspects, and I think tying in some of the issues which we've already heard about in terms of the things like speech and language therapy input there, and aspiration lung disease, particularly in very small children with SMA1, for example, is still very much one of those issues which we are facing. And again, if you don't deal with that properly, then again, you can start to aspirate over a period of time with long-term effects on the chest. We've heard about chest physiotherapy, and part of the problem here is the fact that because muscles are weak, then people are unable to take a deep breath in. So you don't get, if you like, air into all corners of the lung, and secretions build up, and then they can be hard to clear. And so, and of course, the way which we normally clear would be to take a nice deep breath, and we close our glottis, and then we would cough strongly, and that would clear our secretions, and we would be able to sort of stay well and not have chest infections. But if you can't do that, then those secretions build up and infections come in. And actually, some people may cope perfectly well when they're well, but then they start to get an infection, secretions build up, and then they really struggle to deal with that. And suddenly you're in trouble, and come in trouble quite quickly. So we need to have a very active plan about what we do about that. And so there are things that we do to try to, one of the major roles of a respiratory doctor and team, really, because it's not really just me, is to try and find ways of preventing chest infections. And some of that might, for example, be using chest physiotherapy, and that will vary depending upon the age of the child. The type of physiotherapy techniques that are used in a small baby with SMA1, for example, will be very different from, say, an older child with SMA2 or SMA3, if their cough is not strong. And so in older children, you can use things like ambi bags and what have you to try to let people have deep breaths. In younger children, other sort of forms of support will may be needed, sometimes just to be able to sort of move people around and change positions and what have you. So our physiotherapists and chest physiotherapists are an important part of our team to try and guide that. We would advocate, for example, if people did get a bit chesty, then we have a lower threshold for giving antibiotics, for example, in children. Now, that's not to say that you're using it with every sniffle, but the threshold is definitely altered. So again, we would suggest those treatments and presenting early if people are not responding. Little things like get a flu vaccine. I mean, there's a lot of flu around at the moment. And so the idea of suggesting in children that they should all be having flu immunization is something which is relevant. And older children, COVID vaccination. So all of these things have sort of come in terms of how we think about things. So prevention of infection is a big part of what we do. Making sure people are not aspirating and that we're managing from a food point of view, and also just in small children as well, making sure as part of the bigger team that children are in fact growing, because again, if you can't get enough food in, either because it's too much effort or it's going down the wrong way, and then and you're not thriving, then again that has a generalized effect upon weakness, and that includes breathing weakness. So that idea about making sure people have got safe feeds, potentially even small children, nasogastric feeds or even gastrostomy feeds is a big part of what we do. And some of the stuff which we've looked at in Scotland at our patients is that there's still a sizable number of our children who are still aspirating. And so again, you need to look for that. If you don't look for it, then before you know it, they can be silently doing it, and then you're causing trouble. So I think, yeah, important to be aware of those issues. And then the other things which we need to be looking for is much more silent things which we need to be looking out for, like so muscle strength and has a particular impact, particularly during nighttime. We all slightly underbreathe at nighttime, and basically you find therefore that more subtle issues start to become more apparent through, for example, sleep studies. And so we would look, particularly in young children with SMA1, we would be looking, even with the new therapies, to be very much doing studies looking at oxygen levels, carbon dioxide levels, sometimes even more detailed studies to ensure that the breathing is adequate. And we have certainly picked up on children, even children who've started to get in some of these new therapies, who are significantly hypoventilating and need to have extra support with their breathing. And we know from other conditions, and even historically with SMA1 or SMA2, that actually if you can support people with their breathing when they are inadequately breathing, then they do better. And so finding children and then giving them support, for example, mask ventilation support is, and again, we do have one child also on tracheostomy ventilation, which is something which is becoming more available perhaps in Britain for children who are now receiving new treatments in a way perhaps it wasn't before these treatments available, something which was widely done. That we know that particularly with things like mask ventilation, we can try and help people either whilst some of these new medications are kicking in. Once you're in, it doesn't necessarily mean you're on it forever, but we're using these therapies, if you like, to try and support people's breathing, because as I say, they do better, they feel better symptomatically. And there are other reasons as well. We know that chest shape, for example, is something which is still not necessarily normal. We can see quite significant chest wall abnormalities, and for example, plexus excavatum, you might get a dipping into the chest or abnormal chest shape and posture, which potentially, if we're actually treating well with things like mass ventilation, we can make a better wall shape, chest wall shape, that in the longer term may have a better beneficial impact on respiratory function as well. So again, this also may help with form of chest physiotherapy, may help with reducing infections. So there's all sorts of aspects, if you like, which we're looking out for to see whether or not this is the right treatment or not. And it's right for some children, maybe right for a time, and it's something we continue to monitor. And the other thing I just mentioned as well, which I'm afraid has been, in our experience, a bit of a disappointment around some of the treatments. I think someone alluded to it earlier, which is that we are still seeing significant problems in a lot of our children who are not children who've been screened, so this may be different once we get screening in, we don't know yet, is that quite a lot of these children still go on to get quite significant chest scoliosis. The spines are going over really quite markedly in some of our children. And that's a real worry for us for quite a few of our patients. And ultimately speaking, if the chest starts to tip over, then first of all, you can start to collapse different parts of the lung. The breathing mechanisms, the way the respiratory muscles work, the way the diaphragm starts to work, all become misaligned. So you can't get those deep breaths in. That makes the coughs worse. It makes the ability to get infections. And ultimately, over time, once someone starts to tip, then it's very, very hard to intervene with that. And this is a real challenge, because actually doing spinal surgery in potentially very small children is still a concern. So I think that really is an area which I think we need to be very much focused on in terms of things like scoliosis, prevention, spinal jackets, good seating, and things like that, all of which are very important effect, and all of which come back in terms of respiratory function to how well children do. So I think there's these new therapies have changed the world from a respiratory point of view. These children often, in particularly SMA1 children, would have had significant respiratory failure in the first year or two of life and would have required support, and that may not have been enough. These children are now living, but they are still having problems, and I think it's important that they're very actively managed to try to keep them well in the longer term.
Thank you very much. Yeah, definitely a growing list of things to come back to in a second. But I'd like to sort of introduce, finally invite Portia to say a few words. So Portia, it'd be great to hear from you with two hats on. Firstly, as Ezra's mum, and just reflecting on what you've heard so far about how that sort of mirrors or chimes with the experience you've had with Ezra, but also just in terms of your role with SMA UK, the kind of support that sort of SMA UK are able to offer families as they pick up a diagnosis and go through the sort of the kind of treatment and care that we've been hearing about.
Sure, thanks Rob, and yeah, thanks everybody. It's been really interesting just listening. So yeah, my son Ezra was born in 2016, which is right at the beginning of treatments. There was no treatment on the NHS at that point, so we managed to access, with the help of Evelina Hospital actually, nusinersen on an expanded access program, which at the time was only in use for compassionate reasons. So without it, Ezra would have died, and he was actually so severe he probably would have died before he was 1, I would say, because by the time he was diagnosed at 4 months, and that was from seeing quite a few health visitors that didn't really recognize the symptoms, GP that didn't, in fact he was in the Evelina even in PICU with a cold at 5 weeks old, which shows how his respiratory system couldn't cope with a cold already even at 5 weeks. And we were still sent home. So those early symptoms really are difficult. And I think training those frontline workers is actually really, really important at the moment without newborn screening. But that's a whole nother subject. So he got his diagnosis in 2000 and got his treatment, in 2017, by which point he is reliant on a BiPAP ventilator overnight. He's reliant on PEG feeding. He's got very severe scoliosis. Everything that Philip mentioned basically is what I live with on a day-to-day basis. He has 12-hour nursing overnight. He has a nurse who goes to school with him for 8 hours. I mean, we're very lucky that we found a mainstream school that is willing to include Ezra and all his complex care equipment. And that's been quite a struggle, I would say. So SMA UK, I first came in contact with them, obviously, when I got Ezra's diagnosis. And I contacted them and they sent me a beautiful multi-sensory toy pack and they were always there. Their support services were there on the end of the phone for me. And little did I know, actually, how much advocacy work had been going on at SMA UK at that time. That they were working tirelessly with the clinicians, with NHS England, with NICE, to really get these treatments through as quickly as possible. And who knows, without them, Ezra might not be alive, really, because the timing of his diagnosis, if treatments had been available just, 1 month later, he probably wouldn't have been here. So it really is quite incredible. So that's the support services. SMA UK are always there on the end of the phone, talking to families with new diagnoses, as well as adults living with SMA. Of course, with the cost of living crisis, the crisis being getting PAs, they've been very, very busy. And it's a very small service, the outreach and support service. We give small grants for, traveling to treatment, pieces of equipment that can't be funded by the NHS. And the toy packs are still going strong, and that's quite often the first interaction we have with the community of those toy packs. There's a wealth of information on SMA UK's website, everything about living with SMA for recently diagnosed, from treatments to family planning. There's lots of guides you can print off on the website. We've got a section called Living with SMA, which is full of sort of life hacks, ideas, and signposting to other charities as well. As Rob said, we work very closely with MDUK, and on those wider disability issues, we work together in campaigning and things like that. It's been quite a job keeping up with the treatments as they go through, because each one, the access criteria is changing really rapidly. For example, the Zolgensma started off with tiny babies, and now they've stretched it up to 21 kilos. People are having to decide whether to switch treatments, what to do. It's a big decision. I mean, we've been offered gene therapy for Ezra, but I'm very aware that the data in the bigger kids is not as it's not there like it is for the babies. So I have made a decision to hold off, but other people haven't. And so there's lots of decisions for families at the moment. It's a really new and upcoming, and as they were saying, the expectations of the parents, it's a lot for the outreach team to deal with. And we really are, I would say, running out of capacity with the population just exploding like it is. There's a lot of work to be done for them. To kind of help us out, we've started to do some WhatsApp groups, because I find it's really valuable. Well, I found it valuable being able to talk to other parents who kind of understand you like no one else, because they've been through what you've been through. But we find that sometimes these groups can be borderline dangerous, I would say, with parents swapping, medical advice and clinical opinions and the whole expectation thing. Oh, this kid's doing this, my kid isn't doing that. So these WhatsApp, Facebook groups can be a bit toxic. So we want to kind of own it and make a safe space for people to talk and to share experiences, and in the background have moderators and rules so that it's a safe space for people to share basically. So at the moment we've got a teenagers group, which I'm really excited about, because I think it's so important for teenagers, but all teenagers have to go through anyway, never mind living with SMA, to be able to find the like-minded spirit to chat. So that's been really positive. We've got a young adults WhatsApp group, which is fantastic, and coming soon next year we're going to start a family WhatsApp group as well. And on our website, you can find lots of podcasts talking about all sorts of things, from, periods to relationships to school. And there's lots of events going on as well. We did some fantastic picnics in the park last year. Was really great to meet families there. So yeah, lots in the pipeline with the community networks and events. And then my job is advocacy on a wider scale. Sort of, what are the issues that are affecting lots of people? How can we take that to, to the policymakers, to the government, to the people that can make a difference? It's quite a new thing for SMA UK to be doing. But, I've been to parliamentary drop-ins. I've been a panelist at various conferences. I sit on managed access committees, and it's really been quite humbling seeing how the network of clinicians across the UK work together for the best for our community, and they really do care, and they really work so hard over and and above what anyone would expect. And coming from the outside to the inside, that has been really striking for me, just how hard these people work for the SMA community. Yeah, so SMA UK are very, very busy. So yeah, do go to the website. There's lots and lots there.
Thank you, Portia, and thanks everyone. We've got about half an hour left, and we've had some questions in advance, but I'm going to use Chair's prerogative to pick up a strong theme that's come through, which is around kind of almost, and I'm going to put it in, I'm going to sort of cover it in two themes, I think, in two sections, which is, I guess, the consequences of having the treatments rolled out and what that means for families and for services. So I've got two discussion points that I'd really welcome. Firstly, on the impact on services, from what everyone's been saying, obviously we're still learning what the long-term effects is of the treatments and what that means, and we're seeing children at stages we wouldn't have seen them before, and that's having obviously an impact on services. Just be really interested to hear your reflections on what that means, and also not to get too technical, but whether actually the changes in the way in which services are being commissioned, is that actually going to cause bigger problems? So commissioning is becoming more locally based through things called integrated care systems. Some services are staying commissioned centrally by the NHS, which confuses things even further. So just, I'd love to hear your perspectives in terms of how concerned you are about that, and also I guess what advocacy we and groups like SMA UK could be doing in terms of trying to get resource for services. And then I'll come back to family expectations. So if I invite maybe Laurent first, then Elizabeth, and then go around the other sort of panel, that'd be really interesting.
May I suggest Elizabeth first, because as a newcomer in the system, I'm probably not the best person to comment on the way it's organized, but the best I can do is to compare with what happens in other countries. But I have not a longitudinal evolution of the change, so probably Elizabeth will give a much better insight than me.
Okay, yes, of course. Thank you, Laurent. I'll do my best, Rob. So I think just going back to Portia, you very helpfully explained the use of Spinraza in your son Ezra, and that back in 2016 we had the introduction of the use of Spinraza, and this, as has already explained, was not through the standard NHS commissioning. So what I mean by that is that we couldn't just pick up a prescription pad and say, yes, I'm prescribing Spinraza for your child. It was available, as you say, on compassionate grounds through what was called an expanded access program, which meant that the pharmaceutical firm Biogen made it available free of cost to the neuromuscular services to be able to provide that for babies who had SMA. And it was not without its difficulties to introduce that, because although the drug was provided free of charge, there is a cost involved, both a financial cost, but also a resource cost, so staffing and space in delivering Spinraza. So Spinraza is given by repeated injections into the spine, what are called lumbar punctures, and it's not an entirely straightforward procedure, and for some it can be quite technically challenging. And you require the right number of staff with the right skills to be able to give that treatment, and you require the space in the hospital to do that. And you have to remember that, you know, hospitals come under all sorts of different pressures. So someone like me I work in neuromuscular, and I'm thinking within that service, but I then have to go to a clinical director or medical director and say, look, we need to give this treatment and we need to get on and do it soon. And they say, well, where are you going to do that? And we've got wards filled up with children admitted from A&E and so on. So in a very quick space of time, we had to try and work out how we would deliver that. So I'm not going to pretend that was easy. It wasn't. There was then the process of the NICE appraisal. So that's the appraisal system that is used for new treatments in this country, for the NHS to then decide whether or not they're going to fund a treatment delivery. And when it came to Spinraza, at the end of that appraisal process, well, the initial appraisal process was unsuccessful, actually, and it wasn't approved, and it went through an appeal process. Meanwhile, we're continuing to provide it through the expanded access program. But I have to say, not to all children with SMA, because at that stage it was provided on compassionate grounds to those with type 1 SMA. So we were very keen to get it through so that it could be more widely available. And it was then approved through what's called a managed access program. And that means that it comes with quite a few strict criteria that you have to apply. So both as a clinician and actually as a parent as well, you have to sign up to this agreement. And for a clinician, it means that there are a number of assessments that we have to confirm that we will undertake for any child who's receiving that treatment. And those include physiotherapy assessments that must happen at least twice a year, and medical assessments. We also need to make sure that any child receiving the treatment meets certain what they call entry criteria. So, for example, if you're tracheostomy ventilated, you cannot receive nusinersen through managed access agreement. If you're unable to perform the physiotherapy assessments that are needed, you would also not be able to. And then we have to go through a process of monitoring, and if a child is deteriorating on nusinersen, we're actually duty bound within this agreement that we would look to stopping the treatment. And this is something that's discussed with parents when we're entering into this. That explains, I think, a little bit about what the unmanaged access agreement is. The second treatment to be approved here was, in fact, Zolgensma, which was routinely commissioned. So NICE actually approved that treatment for infants with type 1 SMA. It's not tied up in a managed access agreement, other than for those who are diagnosed pre-symptomatically, who interestingly were, because they felt there wasn't sufficient evidence to routinely commission it there, they said that needed to be through a managed access agreement. That's a very small number of children because we're not screening in this country. So that is a treatment that we don't have this contractual process around it, this managed access agreement that says you must do these things and collect this data. But as clinicians, we still have the ethos that it's really important that we make sure to give the right treatment to the right child, and that we have a duty to actually follow up and make sure that we continue to learn about both the safety and the benefits. So, and with Zolgensma, there are some very significant side effects that can be seen with it. So the NHS did say that when we started using this treatment, it was going to be provided in only a small number of centres. So that was the approach that was taken by NHS England. So there are 4 centres. They're in London, Sheffield, Manchester and Bristol, where Zolgensma is provided. And there is a multidisciplinary team that gets together every fortnight to review the progress with that infusion service and to have some oversight of what is happening within that service, I suppose. And the other treatment is risdiplam, this also was provided through an early access scheme by the pharmaceutical firm before we could actually prescribe it more routinely, and had fewer difficulties than Spinraza for implementing in hospitals. I think largely because of the ease of delivery of it. It's a treatment that's given orally and parents give it at home. So it doesn't have that same difficulty of needing a hospital bed to provide the lumbar puncture and the skilled staff to be able to undertake that. And perhaps it was also easier because we'd already been through a process of introducing treatment pathway with the Spinraza. And subsequently that's come through again as a managed access agreement, and the managed access agreement has a lot of similar themes to the Spinraza managed access agreement in terms of the eligibility criteria, but there are also some differences actually in terms of data that needs to be collected. And I think it's probably only right to say that it puts a lot of pressure on the clinical staff to undertake this data collection. Actually, people like myself, I could speak for myself. I see a really important role to try and get treatments out quickly and to provide the right treatment for a child and to do it in a safe manner. I think that's, my really important role, if you like. But if you then ask me to be entering a lot of data onto a database as well, that just puts further constraints on things. And it's not just about me, it's about the multiple other staff who are involved in that. And then I think for parents, it must bring difficulties as well, because they're asked to sign a piece of paper at the beginning of this, that to a document to say that, yes, this is being provided through a managed access agreement. And if these particular criteria aren't met, you can't continue to receive that treatment, and that at the end of a period of time there will be a reappraisal by NICE and NHS England to decide if they're going to continue to provide it. So I think that does put a pressure on people, actually. That's not to say that it's a wrong process to go through, because I'm not a health economist, I'm not the person who takes these decisions, and I think there are immense challenges that are faced when it comes to introducing new treatments, but it does come with its difficulties as well. I don't know if that helps answer the question at all.
No, absolutely. No, thank you, Elizabeth. No, it definitely does. I think if I go to Jenny next, because I think it's certainly my experience of it sitting on managed access oversight groups is that physios have there's a lot of burden on physios to collect data, but also to have designed the tests in the first place. So it'd be interesting to hear your perspective on that. And also I'll go to Philip next, because I'm also guessing that you're seeing an increased caseload, and the question is, are you receiving more resource with that, or is that a real battle you're facing? So Jenny first, if that's okay.
Yes, it's been a huge impact actually on our workload. So in terms of our case numbers, the SMA cohort is not the biggest, but it's certainly taking the most time, because the assessments are extensive and long, and in small children it takes a little bit of time to persuade them to do things. I quite often have to stop and have cuddle breaks with parents. So it's quite a long process. We all had to be trained. We do reliability testing to make sure all of us in all the centres are doing the same tests in the same way. That all takes time. And then actually inputting the data into SMA Reach database takes a huge amount of time. We don't have any admin support in terms of physiotherapy at all. So we have to do that all ourselves. So that has been a huge impact on our time, I would say. And also helping the community physios to learn about the treatments and to learn about the impacts, because they, as I mentioned before, don't have many SMA patients. So we're teaching more webinars and teaching our community team. We have from Evelina, we have a Southeast Network physio team, and a lot of those meetings are taken up on that. So again, that's all time consuming. We also liaise with the other, had a meeting the other day with the other physios from other infusion centres to discuss things that come up from that point of view. And one thing that I forgot to mention before, which is really important actually, is orthotics. And we are very lucky at Evelina that we can prescribe the orthoses that we want. And talking to other physios in other places, they can't do that. For example, one centre has to refer to the spinal team in order and wait. The child has to wait to be seen in order to be prescribed a brace, when I can do it without following that whole process. So it's different in different areas. It's hugely time consuming. I'm not saying I don't enjoy it, but we were lucky at Evelina, because we're an infusion centre, that we did a business plan and did manage to get some extra physiotherapy help. So that has been really, really important. But already that person's time is taken up. So yeah, it's been a big change.
Thanks, Jenny. I think all of it, it's great to hear that perspective of what it means for the service, so that building that empathy between patient groups and families and the professionals, because we're sort of fully aware of MDUK, and SMA UK, well as well as those challenges on kind of service. So Philip next, and I'll come to you, Eleanor, as well. But Philip, yeah, I guess kind of my sense is that physios are at the front line of collecting data, and perhaps you as respiratory specialists are more kind of treating children you've not seen before, and therefore there's an added workload from that perspective.
Yeah, I mean, in terms of, I'm based in Glasgow, and actually we have a slightly different structure in terms of commissioning and what have you. We still have very much an old style health board type structure. We are an infusion centre though, and that means that there's been work that's come to us from all over Scotland in terms of actually providing that. In some ways, I suppose, with commissioning, you might well get more resource therefore that follows a patient, whereas we just have to sort of absorb it, if you like, within what we do, and that has its own challenges. I mean, I think we've been reasonably fortunate in the sense that we haven't particularly had to battle that these are treatments that are coming, if you like. We were one of the centres involved in some of the earlier trials, and so we had patients established, and then once it was established and we saw the results, if you like, we were able to sort of use that as leverage to that we're going to keep doing it. And so the funding around the drugs wasn't a major issue, but clearly then the resource did become more of it, and we've had to make business cases around that, and there has been some. I suppose we are still, in terms of SMA, at a stage where we are. These are intense patients in terms of data collection and physiotherapy, and the team around that and inputting into various different assessments is something which is big. And it's not just the neuromuscular patients around the SMA group. I mean, there are lots of data collection in all of the aspects now around neuromuscular disease, and so that's become much more built into how the patients are seen, how frequently they're seen. Obviously, having to get people down into for assessment, which in the middle of a pandemic was never entirely straightforward either. And so there's a whole world of things which became much more complicated. But I suppose with the SMA1 group in particular, the key thing is that these children are now living. And so what you are having is a situation whereby in the past, you may have 6 patients or so a year presenting in Scotland who would not have survived beyond sort of 2 years, whereas now these patients are surviving, and so every year you get another 6 patients also coming on. So we are going to have a situation of an exploding number over. I mean, it's a great thing, but it comes with its implications. And as I said before, it's not this idea that we have these new magic medicines that's made everything better and go away. That's not what we are. Now, things may be better if we get screening, and I was really interested in the stuff and data that was put there before. But at this moment in time, these children, not just because of their needs to input data, but their ongoing medical issues as well are significant, and I think that is something which is going to continue to grow. So yes, it's still a small part of what we do at the moment, but it's growing. And I think that we just need to understand that as we build the service as these patients come forward, and that's not just, and that's quite broad as well. It'll have implications in terms of spinal teams. It'll have implications in terms of physiotherapy, respiratory, sleep services, ventilation services, and all that goes with that. So it's a growing group. And I think that will ultimately need to be funded. Otherwise, we just end up diluting ourselves to a point of not being good.
Thank you very much. I'm going to come to Eleanor next, and then I'm going to come to Jenny with some physio questions. So Eleanor, I'm going to ask you to reflect on that same issue in terms of your changing role with treatments, but I'm going to try and work in a specific question related to you as well, which is, could you also ask about sort of, are there any specific foods that are best if a child has swallowing difficulties? Was an advanced question we had.
So I would just echo what Philip said, that these numbers are growing, and that then places an impact on all services. But in line with other, SMA is not the only condition where we're getting better at treating it. So we also have growing numbers of patients with cancer, growing numbers of patients surviving prematurity who present with complex medical difficulties that places pressure particularly on our acute services, because we hold the information and knowledge about them, but then also to my community counterparts that are being cuts every time I call a service. There's another sort of reduction in the numbers of people that are available, and you're handing this incredibly complicated patient they wouldn't have seen before with a treatment they've never heard of, and asking them to sort of hold and manage that. And I think that is increasingly difficult. So while the Great Ormond Street's been great at saying, hey, we need more money for this, we need more physios, we need more speech therapists, we need to have better sleep services, etc., we will continue to advocate for that. We also require our counterpart in community to have more money also. Otherwise, these children go out to no support and the pressure on us increases, and we can't really replace the speech therapy service in their community. We can't go into their school, we can't come into their home, or we're asking them to travel 4 hours to come and see me for 20 minutes, you know, when actually that could be done 10 minutes up their road if they had that service in place. And I think that is really challenging, and people really do have to write to their MPs, and they have to really push that in their local areas. In terms of what foods, in terms of swallow and what foods are better, that really depends on your swallow. So predominantly in children with muscle weakness, as the swallow gets weaker, it gets harder and harder to push more solid textures through the throat. So really hard solid foods like, say, bread, crusty bread would be really difficult to eat, but something like a nice thick soup might be a bit easier. But the other bit that goes with that is if your swallow is really not very good, but you're wanting to keep your swallow muscles going, then actually clean water, which may well go down the wrong way, is probably better on your lungs than, say, thick soup. So the question really would be, how good is your swallow? And your starting food groups would then be based on what your swallow looks like, and then where you would expand up to would be dependent on your level of muscle strength, and also your fatigue, and definitely your respiratory function, and how tolerant your lungs are going to be of me having a go at some stuff that might place you at risk. And that's very much done in conjunction with our respiratory team. So it's a bit of a, I've kind of fudged that question and passed it on, but you would need to speak to your speech and language therapist to quantify what foods would be the best place to start.
Absolutely no fudging at all. Thanks, that was a good answer. Portia's put her hand up very politely, so I'll come to her next before I come to Jenny. But this is a good moment, I think, to plug that next year MDUK will be rerunning its audit of neuromuscular services, which we haven't done for 4 years now because of the pandemic. And one of the reasons we do that is to get a really strong picture of what service gaps are and the challenges that services are facing, to then work in partnership with services to make those business plans and secure that resource. I think that's going to be more important this year than ever before in terms of that changing commissioning landscape, because we'll be using that as a tool to then help engage groups like ICSs and ICS and integrated commissioning boards to really highlight why that investment is needed. So working in partnership with other patient organisations like SMA UK, but also directly with you guys as the sort of specialist health professionals is a really key part of what we do. So I'm just trailing that, and there'll be a large patient survey element of that as well for those in the audience. So watch out for more information on that in the new year. Portia, I'll come to you because your hand up, and then I'll go back to Jenny with a couple of physio questions.
Sorry to butt in, Jenny. I just wanted to say what Eleanor mentioned there about the problems in local service providers is really the biggest problem our community are facing at the moment. Access to community physios is just few and far between. I know personally, Ezra hasn't seen his community physiotherapist for any kind of proper session this year. We haven't really seen her. She's dipped in and out to have a look at a chair now and then, but there just isn't the capacity, which means parents are going privately. They're having to spend their own money, and they're spending their own money on private physios that don't necessarily understand SMA, which is worrying, because although the neuromuscular centres are working really closely with the NHS community physios, the private physios I don't think are getting that same input, and that's where the parents are going. And it's not just physios, occupational therapists. I know children that have just had to lie on the floor for 3 months while they wait for a supportive seating chair. Yeah, it's a big problem, and lots of our outreach phone calls are about that.
Thanks, Portia. So yeah, Jenny, back to the question that Laurent trailed for us earlier, which came through the Q&A function. Really interesting question, and we'll focus it on physio rather than other therapies. But is there any research that indicates how much physiotherapy, in this case, input is required for treatments to have effect? Or is it more around measuring the impact of the treatments, if that makes sense? If I go to Jenny first, and Laurent's put his hand up, so we'll bring him in after you.
I'm not aware of any research that shows how much you need, is the short answer. When all of these treatments started, we were hoping that they would stabilize the condition, and actually seeing functional benefits and improvement in scores was not really anticipated. So with that in mind, we need the physiotherapy. You need to use the muscles to try and keep the muscles. So if you're having the medication, which is doing that, you need to then You can't just sit back. You need to use those muscles. But physiotherapy is, it doesn't have to be hands-on physiotherapy. It's activity, it's movement, it's play with the little ones, it's doing things that they enjoy. But I'm not aware of any research which puts a figure on how much. But not to say it isn't really important.
Of course. Laurent?
Yes. I'm not aware neither, but the good news is that I'm aware that one will start soon. Because as a newcomer, I must say I was a little bit surprised to see the amount of physiotherapy that is provided in the UK in comparison with other countries. My patients in Belgium have at least 3 physiotherapy per week, including the ambulant that are probably more like 2. In France, it's closer than 5 than 3. So the amount of physiotherapy in the UK in comparison is quite low. Is it better or not? I don't know, because well, I guess it's better to make physiotherapy, and I'm pretty sure that the physiotherapists will agree with me. But there is no hard evidence that then if we could improve and increase the amount, not only to increase the amount of physiotherapy, but also to improve it by applying strategy that are well adapted for patients. So we are starting a research to try to bring a little bit more evidence that if we could optimize physiotherapy in patients in a group of patients in the UK, we could maybe observe a better outcome. So is it feasible? Is it acceptable? And does it translate in a better outcome? That's the question that we are asking in this research. I think it's key, to be honest, because from my limited experience, when I compare my patients in France or Belgium and the patients coming from countries where there is no physiotherapy, even less than in the UK, I feel, but again, this is gut feeling, this is not hard evidence that we should really super expensive treatment with something as simple and efficient as physiotherapy and exercising in these patients. I deeply feel it, but I don't have the hard evidence. So that's what we want to provide in this research.
Brilliant. Thanks, Laurent. We've had a really good question come in right at the end on the Q&A, so I'll make this the last question. A couple of the points raised by others that I'll try to address in my sort of concluding remarks, but conscious that I'm running out of time. So Jenny, I'm going to direct it to you, I think, first of all. So the question is, what is the potential for strength and functional gain from exercising for SMA children on treatment, and what type of exercises are best? So I think we've heard a bit about how some of the treatments were, the data really is stopping loss of function, but actually some function has been regained. So is that possible through physio and exercise? Is that something you're seeing?
Yes, with some children, but it's really very individual, because the children are not all the same anyway. They all developed symptoms at a different age. They're all at a different stage of disease progression before they got treatment. And that's one of the problems that we've talked about before with expectations. So families are comparing with each other, and it's not a true comparison. So yes, there is potential for gain, but I can't really say this is what you're going to achieve, because it's all very new. So we've got children with type 1 SMA who are standing in CAFOs. We've got some that aren't and are not going to, being realistic. So it's really important that assessment is individualized, and aims are appropriate and realistic for any particular child. And the aims, it's not all about standing. For some it is, for some it might be being able to roll over in bed, it might be able to get from sitting to lying. So the functional aims have to be appropriate to that child, and I don't think at the moment we can say this is what this child is going to achieve, because we're still very much learning.
Brilliant, thank you. I'm going to call time on us now. Thank you so much to our panel. Marion Main in the Q&A has reminded me that Treat SMA were another patient group that we worked alongside and still are working with in terms of access to treatments. Given the size of the panel, we can't invite everybody we'd like to invite. So I've struggled to manage this number. So thank you very much, everybody. It's been a fantastic 2 hours. Really value the time you've given to us, and the recording will be available shortly. Thanks again to our sponsors, PTC Therapeutics, Novartis Gene Therapies, and Biogen. And yet we will make this recording available online over the next few days, and also on our website you can see all the other previous seminars, both from this year, but also the previous SMA seminars from previous years as well. So thank you very much. We could definitely have done another hour of this. We had lots of other things we could have covered, but really value your time with us this morning. Thank you very much. Enjoy the rest of the week, and have a good Christmas when you get there, everybody. Take care. Thank you. Bye-bye.
Thank you.
Thanks.
Thank you.
Bye-bye.
Bye-bye.
Bye.